Thank you, guys.
Thank you.
At least we weren't backslapping, saying, "Oh, Chris, you're amazing." Chris, you're amazing, and blessings, you rock. Right, and last but not least, we have. The question is, this is a pub quiz question. Which specialty does all the cool innovation-y stuff in the whole of healthcare around the world? No. Primary care, no. Managers, no. Tech firms, no. Military, no. And this is also another a side question. Of all the specialties, who are the nicest, kindest doctors that you want to hang out with? Yes! Is the answer. The paediatricians innovate loads, in my opinion, and they're so nice, such nice people. I mean, you have to be, wouldn't you? I mean, I don't think I could be a paediatrician. I don't even hang out with my own children, let alone other people's. Right, over to you.
With the easy pitch that children's health innovation is the place to be. So my name's Darren Gates. I'm a paediatric intensive care consultant in Alderhay Children's Hospital in the north of the country in Liverpool. And I also get to work part-time as a clinical innovation consultant in our innovation hub, which I'm going to tell you a little bit about. It does touch on productivity a bit, which I think is the theme of the afternoon, as well as some mental health as well. But before I do that, I just wanted to address the question at the back around technology. And I think one of the best integrations of technology is making the invisible visible, but the visible invisible. So it's kind of not getting in the way, but actually showing us things that we couldn't see before. And I'll touch on that as well towards the end of the presentation. So this is beautiful Liverpool. So historic city in the northwest. Unique challenges as a city, particularly as a paediatric standalone hospital, where we're both a district general hospital as well as a tertiary and quaternity centre for specialist services. But in our city in particular, 20% of children under 16 live in absolute poverty and 30% in relative poverty. And of 317 local authorities in the UK, we rank, I think, 5th now in the table for the most deprived. So whilst we're doing well in the Football League at the moment, we are not doing well in deprivation. And that means that we see a lot of acute and chronic conditions that reveal that particular problem. And I said I was going to mention mental health as well. That is absolutely an increasing problem amongst young people, particularly amongst the most deprived. So some stats there of how that's changing across the years, and I know there's all sorts of trends contributing to that. Research suggests that 75% of mental health problems are established before the age of 24 as well. So if we're going to tackle some of the population trouble with this, tackling it in children is important. This was the old Alderhay, which was standing for a bit over 100 years, has a long history of innovation. We were the first to test penicillin in treating pneumonia in a child, and from my own specialty, the first paediatric intensive care unit in the UK as well. But in 2015, we moved into this new hospital in the park, which is set in a health campus, digitally enhanced facility, and an executive board that is really behind fostering innovation as a key activity within the hospital. Play and access to nature is a key part of that design, and I think Talak mentioned before that working in a children's hospital is one of the places where you do get to engage in that kind of activity with kids regularly, and we did have at one point Tesla cars driving around to get you to your operation at certain points. But we are constantly trying to innovate, and we are unique in the sense that we have a 1,000 square metre innovation hub in the centre of the hospital. So The first, I think, dedicated hospital-led and hospital-sited innovation centre in the UK, at least the largest within a hospital. And a growing team of around 38 people from clinical and technical backgrounds to do problem-led, need-led innovation. And that includes different labs, so artificial intelligence, rapid prototyping, automation and immersion. So it is a space that's continually evolving, and we are really open to academic, industry and commercial partners coming to collaborate on innovations. And we want to be that kind of melting pot for where those ideas do come together. We have significant partners in the region, including the Hartree Centre, which is a supercomputing and now quantum capability centre, which we're, again, spinning up projects with. And we have a daring ambition to solve some of the biggest problems in healthcare, and particularly to tackle them early. This is just to give you an overview of the evolution of our hub, and really to say that we just tapped into essentially different resources and different problems to fuel the development of that particular centre. So that started with some grant funding, moved into a more commercial type phase. Then we had the blip of the pandemic, which was actually a real blessing in terms of bringing lots of problems to the fore, and us needing to really rapidly do things about that into further commercialisation phases, and now setting a new strategy for futures. The Rapid Prototyping Centre was particularly of value during the pandemic, where we tested essentially products that that helped with infection prevention control, as well as simple things like facilitating communication when you had your mask on with children that couldn't actually see facial expressions. So one of our speech therapists helped develop clear masks to maintain that barrier but still engage with the children at the time. So yeah, just in terms of finding problems, identifying problems from the clinical need is one of the things that really drove us forwards. We have key focus areas across digital platforms, health tech, AI and data use, immersive, and improving patient experience with engaging platforms as well. And one of the first things that I was involved in was building a natural language chatbot to engage patients in their journey within the hospital. And we're keen that these interventions across these different areas have a big impact to care. So actually the socio-technical aspects of deployment are a big area of focus of how do we actually get some of those products that have been designed into the hands of families and clinicians to use. This is just a quick overview of our process to say that, again, it's a needs-led and quick kind of turnover activity where we'll try and identify the key things that we can focus our attention on, including just a kind of front-end portal for clinicians, but also for SMEs to bring ideas and solutions into the pathway, and then for us to iterate on how we can actually meet those, match them with subject matter experts within the hospital. So I want to give you just a quick overview of some of the projects we've been working on. So we've been doing a lot of predictive analytics within our data science team, which is where I sit predominantly from the innovation hat. So we've been looking at predicting attendances within the ED. So how can we actually allocate staff and resources appropriately during different days of the week, different times of the month around predicted attendances, and then the likelihood of each of those patients being admitted to the hospital to facilitate with bed flow. This is a particular presentation of asthma mapping. So it's looking at where the hotspots of our admissions for asthma actually occur within the hospital, such that targeted interventions with families and GP practices that work in those particular regions can have extra resource really to try and identify problems early and prevent the escalation up into the A&E. And then this machine learning tool called Was Not Brought was around predicting the likelihood of attendance at an outpatient appointment, and it used a number of features from patients' previous presentations and known diagnoses, known backgrounds, including deprivation, as to whether they were likely to be unable to attend an appointment and whether extra prompts could help them arrive at their appointment in a timely way. And obviously being aware of the fact that a child is brought to an appointment and that it's not that they don't attend, it's that they haven't got there for some other reason that the family was unable to bring them. And we found that in terms of feature explainability within that model, there were lots of reasons why people couldn't attend appointments, and in different areas and in different clinics, those targeted interventions could be addressed more appropriately. So we've seen both an increase in productivity around the access to those clinics, but then also providing alternatives for them, such as telemedicine conversations. This is another product that I want to talk a little bit about that helps address some of the sickest patients in the hospital. So congenital cardiac patients often have significant needs, both whilst they're in hospital, but then also whilst they're at home. And prolonged lengths of stays occur where you're trying to actually work out that threshold of, can they get home safely? How do we monitor them whilst they're at home? So the team developed a tool called Little Hearts at Home, which essentially helps monitoring these patients around our region and facilitating community health nurses to go out, assess their weight, their saturations, their feeding, and feed that back into the clinical teams to give us a constant update of how those particular children were progressing. And that's facilitated a lot of things, particularly from a patient experience point of view. Matilda here could get home for Christmas with her family while still being monitored more closely. We have been able to expedite certain care for patients when we've seen a fall off in saturations, meaning they need to move to the next stage of palliative surgery, as well as, again, encouraging feeding so that they can gain weight and would be suitable for their next intervention. So whilst at the moment that's just spot monitoring from community teams, it does engage the community teams in doing that. We're also looking at ways to do continuous monitoring for some of those children at home. We talked about productivity gains with ambient AI. So this is a tool that we are just piloting at the moment within the hospital called Lyra Bird Health. It is an ambient AI tool that listens to the conversation in a clinic consultation and documents in a structured format that particular conversation. The clinicians that have used this in clinic itself think it's magic, because it literally does listen to that whole engagement, to the background, the examination, the plan that's been formulated, and filters out all of the kind of conversation around that, puts that into a nice summary for the clinic, and then can generate a letter to summarise it and send out. So there is, for the people that have used this so far, definitely an aspect of putting the joy back into medicine, which has increased that engagement with the patient and allowed the recording of essential information. I did a ICU hot week last week, And I think I probably documented about 5%, if that, of the things that I actually did during that week. And I think, so that makes you reliant on the team behind you to record some of the things that you are doing as you walk around. But it also means that the data capture is poor for informing the next person that comes along what happened, and using that for more advanced analytics. So I think when this gets integrated into those kind of workflows as well, it will be absolutely game-changing for that. So valuable data, not just from a medical legal point of view, but to actually fuel what the next intervention is. Skipping on, yeah. And I think the influence of digital technologies is already unmistakable, but the current pace of change does indicate that we are just at the beginning of that. And I think, just as a straw poll of generative AI users, who uses some form of generative AI in the room? Who uses it only for personal? Who uses it at work? And who uses it clinically? Okay, 1 or 2 hands by the end for clinical use cases. And I mean, I think everyone that has obviously interacted with that technology will recognise the impact that is going to have over the next few years. And I wanted to talk very briefly about a particular area of interest for me, which is utilising the underlying technology around Gen AI, so foundation models in digital twins of patients. So you will have probably heard the term digital twin as a digital representation of an asset, a physical asset, and that communication between the real and the virtual is a two-way communication, and one informs the other. So if you update the virtual twin, there is a mechanism by which that gets back into the real space and goes around as a virtuous cycle. Ideally, that is in real time and creates a living and intelligent, evolving model of the patient or the artifact. And there are different levels of abstraction that can be applied to. So I want to talk specifically about how that can be related to a patient and in intensive care. But let me just show you a step further back level of abstraction. This is agent-based modelling from a paper from Mayo Clinic, which is essentially looking at the ICU as a digital twin, so a physical environment with agents operating in it. If I can get this video to play. Nope. Can that be played from the back? What you'll see here is essentially the staff in the intensive care unit all hovering around the central areas, patients around the edge, modelling the acuity of patients in each of those areas and the movement of staff within the ICU. And then you can simulate different scenarios of increased acuity of patients in cubicles. So if there is more deterioration, the burden that puts on staff within the intensive care unit. You can start to look at predicted metrics of survival within intensive care for that, and clearly allows a kind of resource planning aspect to the care delivery in intensive care. They've used a hybrid model in that particular scenario to try and simulate patient acuity, like I said, as well as the staff movements, but the potential to focus down on particularly patients and modelling their trajectory during an intensive care is something that is increasingly possible both from a machine learning perspective and also from a data acquisition perspective. So the idea here is that you could look at both patient state and trajectory during an ICU course. you could obviously abstract that back to a longer time period in any particular pathway of healthcare, and even over a whole life course. But being able to monitor how a patient changes during a particular time frame and spotting how they change in comparison to another patient is one of the kind of key tenets of intensive care, really. You're drawing on your experience of how someone has moved, looking at the particular pattern of information that you have in front of you, and relating that back to another scenario. And we're doing some work at the moment around clustering patients based on sort of meaningful ICU states of stable and unstable, and then looking at how you might be able to predict as they move through ICU from the different data streams that we have available from ventilators and physiological data on how they'll progress. So that clearly would allow us to look at things like risk scoring of particular patients and planning care, some smart alerts, and then correlation, like I've said, between different patients. So comparing them both to how they were at the start of their ICU stay, but also to other patients at particular time points in care. And that can be really helpful for how you actually communicate with a family, and also manage the resources that you have on ICU. As I was saying, just this can be abstracted back even further to just clinical care in general, and this was from a cardiology paper, just again looking at actually how you run this through a particular patient's visit in clinic. And you are taking patient-specific data, building a specific patient twin from that, using that to actually construct a normalized version of a patient that would present to a cardiology clinic, and then that can be used again to fine-tune specific patients. And so just in terms of thinking where things are potentially going with that capability within machine learning, I think this paper, which is now 2 years old, from Dr. Topol around multimodal AI, I think is really where a huge potential lies in making the invisible more visible. So seeing the patterns between some of these different streams, diverse points of data, and again, in the intensive care environment, that is looking at both imaging data and physiological data alongside each other, which we do intuitively as clinicians, but we can't do all the time. And so using AI to be able to spot some of those patterns is what we want to be able to achieve. And then developing infrastructure that can actually support that real-time stream of data, analytics and machine learning. And that would result in, as we've said in the previous presentations, a gifting of both insight from patterns of data that we wouldn't see, but also releasing time back to clinicians to actually process it and release the burden of lower level work, the documentation aspects. So this is the team. In fact, it's not. It's about half the team, but it's quite hard to get everyone together from busy clinics' point of view. But we are very keen to engage with SMEs, industry, academia. So if you haven't seen our stand over at A10, there are some examples of some of the products over there. And I'd also encourage you to access our website and fill in either a problem or solution that you have developed and are keen to test within the hospital environment. So and this is one area that we'd really like to engage with even more people. Thank you very much for your attention.
Could you go back 2 slides?
Yes, yes.
That's absolutely amazing. And the offer of actually saying, come and talk to us, and we want to engage with you, and we've got all this stuff, infrastructure, and we need your help. No, forward one. Where are you in that photograph?
Yeah, exactly. I was going to choose the one that I was
He
in.
AI'd himself out of that photo. Right, any questions? I know we kind of run over a bit, but it's such an interesting topic.
I thought there's some amazing stuff in there. There was one question that sprung to my mind, which was related to the early discharge support and the remote monitoring that you're able to provide to children. In adult models, I've sometimes not been convinced that the patient wouldn't have been discharged anyway, and this was treating the anxieties of the clinical team more than it was actually treating the patient. Have you got evidence to suggest that you are really supporting an early discharge in a kind of hospital at home setting for that cohort?
It's a good question. We've got about 100 children, families enrolled on that programme at the moment, 50 of which are actually out in the community, I think, at the moment. So it's probably too early to say. The impression that we've had, particularly from Matilda's case, was that there was a real reluctance to allow home visiting at such a distance. So I think that was one of the things across the region that did facilitate. So you might have said they could go this far or something, and actually that did support that particular decision. Yeah.
Another question.
Hi, thank you very much for the presentation. I'm curious on ambient AI because we've heard across the conference the promise of it. What speech-to-text technology did you use? How quickly were you able to get it to production? And how are you seeing that technologies or companies doing similar things are differentiating themselves with that technology?
Because that's a particularly crowded market, isn't it? 'Cause
It is,
an awful
yeah,
lot about
yeah.
that.
Yeah, so there are lots of offerings available. We use different speech-to-text software for radiology and other aspects. This was actually a company that approached, it's Australian-based, I think, and I don't actually know which foundation models they've based it on. They essentially demonstrated two particular forms that worked particularly well. So a clinic environment, and so a new patient and a follow-up. And they've actually trained it in such a way that whilst the speech-to-text, I think, is fairly ubiquitous in terms of the different offerings, it's quite hard to differentiate between them. This was something, the way that it actually did fill in and structure the output was really quite impressive for us. So that's why we're running the pilot with them.
And I'll ask the last question. Honestly, I absolutely love that. I love that photograph, particularly as you're not in it. I think, Sarah, we can go away and think about how we can recreate something like this. We haven't got a massive budget, but I think what we're saying is any organisation of any size can do stuff like this. You get to a point where it gets its own momentum. My last question is, like, are your staff happier? Are they more likely to stay with you as a result of this, being able to get involved in the Innovation Hub?
Wow.
Have you measured it, or do you feel like...
Have we measured it? The patient and family engagement has been something that we've definitely noticed across the projects. I think staff do find that having an outlet in terms of where do I take this particular problem? They don't always find it met in our solutions because it's not always an innovation problem to solve, as in the computers just don't work fast enough. Yeah. That's, I think, everyone's gripe about doing some groundbreaking innovation when the basic stuff is still not working. But actually, these things have helped us leapfrog forwards in different areas. So I think it definitely has improved.
Well, everyone's smiling on that photograph. So there you go. Thank you so much once more. But and For everybody else, a big round of applause for you lot, because you've stood the test of time. You stayed until the bitter end. And now, as far as we're concerned here at Giant, it's Christmas holidays. So Merry Christmas. You don't need to go back to work, do you? Is that Christmas starts today? Take care, guys. Have a safe journey home, wherever that is.